Nice. Okay, good. Okay, so for those of you who are not familiar with the Right Care Initiative, I should just say that we have been gathering for 12 years now, some of us. Dr. Demaria, welcome, Dr. Joe Sky. Thank you for taking time out of your hospital service in cardiology today. If people could mute their phones, we're hearing a lot of interference. Thank you so much. So I just want to say that we have leadership on the line from our very first University Best Practices in San Diego. Tony DeMar is our there, and he will be speaking to us in detail about the nexus between cardiovascular disease and COVID-19. And we also have our wonderful Capital Region Chairman, who Dr. DeMaria introduced me to. It turns out Bill Baumer was Dr. DeMaria's fellow way back at UC Davis when they were early in their careers, and they remain great collaborators today. We also have leadership from our Bay Area group with us, and Dr. Sky participates in both our Bay Area University Best Practices and our Capital Region University Best Practices. He is the Chief of Cardiology, Preventive Cardiology at Travis. And we also have leadership from our Los Angeles group with us, one of our co-chairs, Dr. Steve Chen, who will be speaking with us about Pharmacist on the care team. So just a few reminders about what the Right Care Initiative is. We are a private-public collaborative that was established in 2007 and have been meeting publicly since 2008. And our goals have been very straightforward. We are driving down heart attacks, strokes, and diabetic complications. And we're doing that primarily through driving 3 specific clinical metrics, which are the underpinnings of the Right Care Initiative. It's not all we do, but the core is controlling cholesterol, blood sugar, and blood pressure. And through those things, we have made great progress. This session, as you can see, is being recorded. And if you would please go to the next slide, Megan. And most of you know me, so we're just skipping through the agenda here. I think you all have the agenda, so let's go to the next slide. So on our webpage, and I won't go into a great deal of detail, this is our project brief that describes what the goals of the Right Care Initiative are and our strategies and our partners. I want to say a great thank you to our supporters, without whom we could not be doing this work. And we're so grateful for our staff who have done a wonderful job in just-in-time learning, not only to move us to the Zoom platform in this urgent situation, but also just to teach all of our older folks how to use these new platforms. So we had such a big interest in this work that we now have 99 people signed on. And if there's need for overflow capacity, this is also on YouTube Live. So next slide, please. And next slide. So these are some of our partners. We have been so blessed to work with amazing groups across the private sector. I want to call out Blue Shield in particular. I also want to call out all of our university partners. We have multiple UCs on the line with us now, plus the University of Southern California. I don't know if Stanford has signed on yet. US military, US Air Force, the California Department of Public Health, the Los Angeles Department of Public Health, the US Million Hearts program of the Centers for Disease Control and CMS. We have been supported by just wonderful members of all across the stakeholders in healthcare in California, including biotech, including foundations. And our most recent foundation supporter is the Health Trust. So we are so grateful to Rand Corporation as well. They're not on the line with us now, but they have been instrumental in developing the intellectual work here. Would you go to the next slide, please? So I just want to say that all of our amazing leaders are on our website. Next slide, please. And this is the core of what we do, the promising interventions, which include the clinical pharmacist on the care team, following protocols, and patient activation, intensive ambulatory care. And in this moment, I would like to say we're all learning as we go, and bless our speakers for working at the very edges of trying to teach the community how best to cope with this emergency. Next slide, please. This is a database project. Next slide, next slide. And let's pause on this beautiful slide. What we do matters through collaborative efforts led by University of California, including Dr. DeMaria, Rand, UC Berkeley School of Public Health, Steve Shortell. What we did with that triangle of promising interventions and using the data to drive improvement was we dropped heart attacks, acute myocardial infarctions in hospitals very substantially compared to the rest of California. Next slide, please. And now we're facing a brand new emergency. So what this slide shows in that red jagged W shape is that we have been dealing with a different kind of influenza-like illness. And with that, I'll turn it to Bill Baumer. This is data from the Centers for Disease Control that we were just looking at on how odd the pattern was, where our public health officials were able to pick up very early that we were seeing in America a much greater level of influenza-like illness and a very different pattern than normal. And with that, I'll turn it over to Dr. Bill Baumer, chairman of our Capital Region Group, who will start talking with us about the nexus between COVID-19, SARS-2, and cardiovascular complications. So Dr. Baumer is a very famous cardiologist, highly published, practices at UC Davis, as well as leading oversight for the state of California on outpatient clinical aspects of cardiovascular care. And as you can see, he is honored by so many. And let us go on to the next slide, where Bill can start talking with us about the wonderful work that he's doing, helping us lead our way through this crisis.
Welcome, everyone, and I want to certainly express our gratitude for you taking the time out of your day to join us in really a very important topic in a very important issue that we're now dealing with. Next slide. So we're here today because of a specific item, and that is the coronavirus, which I showed on the prior slide. So coronavirus is it's a common virus. It's responsible for almost a third of the common colds that we have. It's been around for a long time. It looks like it's relatively stable, does not change its DNA, but it has the ability to cross between human primates, other primates, as well as other animals in the world. And if we look at the coronavirus population that is out there, the alpha and the beta strains are shown there. And they're responsible for a number of infections that we see in animals and in primates. We're all familiar with the fact that MERS and SARS were prior COVID viruses that came out that were highly infectious in those individuals and did lead to deaths at that time. Since then, COVID has continued to exist in many mammals. It's obviously population in bats is consistently seen each year, and so it's a significant problem that we have to deal with. It easily hops between species, and so close communication between animals, bats, and other mammals and humans leads to a transfer from one mammal group to another. The COVID-2 or the current COVID-19 is pretty close to the SARS-CoV-1 virus that existed years ago. Next slide. So this is what the COVID life cycle is for both 1 and number 2, COVID-2. And you can see it is a virus, which is a small RNA virus with a lot of amino acid chains in it. It literally has spikes that bind to a receptor, the ACE2 receptor, after activation on the cell, moves into our cells, and primarily the respiratory, but many other cells it can enter as well. And then you'll see that the process of replication within the cell requires a number of significant proteins, replicase, and other converting enzymes to translate it, proteolyse it into the ability small segments so it can be replicated by the cell. And then from the cell, it moves on to get an envelope, and then it is, in fact, exits the cell as a vesicle with the actual plasma membrane of the cell surrounding it. Now, the purpose of showing this is that there are specific proteases and replicases that are involved in this process. There's a specific docking protein that is required, and that gives us, from this information, the strengths of the virus and the weaknesses of the virus. This virus is a killer. Instead of the common cold, this virus kills 2 to 3% of all people that encounter it. And so it is a really killer virus, but it has weak points, and the weak points are seen here in the specific processes that it goes through. It has a very thin membrane or shell or plasma membrane that's around it, allows it to dry out. And this virus, as you can see, cannot swim to another person. It does not have flagella or anything else. It has to be transmitted by the person who has the virus. That is conducted. Next slide. So that tells us that this is a very fragile virus. It dries out easily, and it can't move by itself. It has to be conveyed. And that's why we use what's called social distancing. Staying 6 feet away allows this virus not to travel to the next human and contaminate that individual. In addition, we show on the slide on the right, in trials that were done at Stanford and other places, that it is subject to heat. The hotter it gets, the faster it dries out. And this small plasma membrane that surrounds the virus, the RNA of the virus, can dry out and then is no longer able to be infectious at that time. So that higher heat is a way of drying this out and leading to disruption of the membrane, which are also easily is also disrupted by surfactants like in soap or detergents. Alcohol and bleach can easily destroy it. So it's a very fragile shell that is there. It's sensitive to heat and it's sensitive to UV, even more so than influenza. So even though it's a killer virus, it has a lot of weak points both in the replication and in the survival of it that can be exploited by us to, in fact, prevent contamination and transfer of this virus. Next slide. And this just shows that the surface of the virus is important. If we deposit it on copper, it drops a log or 90% within about an hour. Cardboard is about 4 hours, and stainless steel and plastic are about 12 hours for it. So it does not completely go away, but most of it, 90% of it, in fact, degrades in about anywhere from 1 to 12 hours on surfaces for that. So to be conveyed and contagious, it has to stay moist, it has to stay in an environment without high temperature, and it has to be propelled from the individual who has the virus to another subject at that time. The most common is droplet contamination at that point, but it can also be aerosolized in certain situations in the hospital for it. Next slide. And so in summary, what we see, this is a very potent virus. It's a killer virus at 2 to 3%, and individuals that Tony will talk about with existing cardiovascular disease, diabetes, or hypertension, it goes up to 10 or 15% in those individuals. And if you're old and have concomitant disease, it can get even higher, as high as 50%. These viruses are all within the beta coronavirus family, which have been around for probably millions of years, highly similar to the SARS virus that was previously around, and MERS. It uses an ACE2 receptor as an entrance to the cell, and it's an enveloped virus with a very fragile surface. It's sensitive to heat, detergents, and solvents. For that reason, this is why we are practicing social distancing on this call today. We are trying to prevent contamination by close contact with that. We're trying to use protective equipment in the hospitals to protect face masks, to prevent contact at that point in time. And until we actually develop immunity from this, from either vaccination or herd immunity, we are all subject to this particular virus. So we're going to discuss that, and we're going to discuss the fact that this virus preys on individuals with existing cardiovascular disease and the elderly. And for that reason, it now represents a significant comorbidity for our individuals that we're seeing for that. So with that, I would like to move to our next speaker. To practice social distancing, we're going to be talking about the influence of SARS-CoV on the various systems of the heart. It infects the heart significantly, as well as the respiratory organs and others as well. And for that, I'm going to introduce Dr. Joe Skye. To Tony and I obviously have known each other, and I was we worked in the same office. He was my mentor and chief, first boss. But to maintain social distancing, instead of me introducing him, I'm going to have Joe Skye introduce him. Joe is, in fact, the chief of cardiology at the Travis Air Force David Grant Medical Center for that. And we have some relationship because Joe received the first traveler's COVID-19 in the US, and I received the first community-acquired COVID-19 patient in the US. So we actually shared early on some similar experience related to that. With that, I'll now introduce Joe Skye, who will be introducing Dr. DeMaria.
Hello, I'm very honored today to introduce Dr. DeMario. He is a master of the American College of Cardiology and started his cardiology career at UC Davis as a founding member of the cardiology program there. And I see now that the slide has changed to the slides for the data on COVID-19, so I'll get back to the introduction. So for the COVID-19 data, one of the important things that we should take some time to notice is that not until the last week have the deaths from COVID-19 even come close to the daily deaths that occur from cardiovascular disease collectively in the United States. And this graphic, as it plays, shows throughout the end of March and up through the beginning of April, how heart disease remained the #1 killer on a daily basis. And cardiovascular disease collectively, when you add in hypertension and stroke, still, even for these past couple of days, COVID-19 only ties with. And so the thought that I would like to raise to our attention is our communities, our political leaders, our patients all expect us to adequately treat and protect us from COVID-19. Wouldn't it be an interesting world where if we continued to maintain the awareness of the deaths from cardiovascular disease that are at a near equal level, if we could continue to bring that type of focus to cardiovascular disease? And just to point out that the idea that this is disease that is going to happen anyways in the elderly, that is from data from Loma Linda, where I went to medical school with the Administer Health Study, and from the Blue Zones. Cardiovascular disease robs us on average of 10 good years of life, somewhere between 10 and 15 when you look at the Nurses' Health Study and the Physicians' Health Study. And so we're not just talking about elderly people dying, we're talking about loss of good years of life. Next slide. And so again, just to put this in perspective, COVID-19 is a very serious thing, and we're dealing with it appropriately as best we can. But in orders of magnitude, the amount of hospital admissions and resources put towards cardiovascular disease every day is significantly more, and it's ongoing. Next slide. And as we all know, the majority of cardiovascular disease is preventable. The American Heart Association consensus number is 80%. We have effective preventions and treatments for cardiovascular disease available to us. Next slide. And so now back to the introduction for Dr. DiMario. Again, a master of the American College of Cardiology, one of the few chosen to be the best of leaders. He started at UC Davis as a founding member of the cardiology fellowship there, was the first to bring echocardiography to California, and soon became a technical and clinical expert in the field of echocardiography, and went on to become the editor of the Journal of the American College of Cardiology for 12 years. And I think one of the important things to recognize is that he's been mentored by some of the best, and he continues to be an excellent mentor, as Dr. Baumer has already pointed out. And the work that he's done with the Right Care organization is impressive as well. As Hattie has already pointed out, the San Diego County project was something that he led by forming a steering committee for Be There San Diego with an attempt to create a heart attack and stroke-free zone. This was work that went on to become nationally and possibly even internationally recognized for the powers that risk factors for cardiovascular disease can have when they're properly controlled. And so it is with great pleasure that we are lucky to have Dr. DiMario speak to us today.
Thank you for that over-the-top introduction, Joe. Hattie asked me if I would join this group this morning and talk about the nexus, the overlap between COVID-19 and cardiovascular disease. And there is an overlap that's being increasingly appreciated. So I'll just try to give a a very general overview without getting into the weeds too much, to maybe bring up some topics that we can further discuss during a question and answer period. Next slide. So Bill kind of discussed this already, but I will just point out to you that one of the major cardiovascular reasons to be interested in COVID-19 is that the way that the virus enters the cell, and that's any cell, the cells throughout the body, primarily in the lung, of course, and that's received the most attention, but in blood vessels, in heart, and kidney, almost everywhere. And the way it enters the cell is via the ACE2, the angiotensin converting enzyme 2 receptor that sits on the cell. And so therein, since ACE2 is so important in cardiovascular health and physiology, it shows the interaction between this coronavirus and the cardiovascular system. Next slide. So initially, all the focus for COVID-19 was on the lungs. There's a terrible pneumonia, and most patients who got very ill and died because of pulmonary failure. And it's just been recently that there's been attention that's been directed toward the cardiovascular system. You can see here from the Kaiser Health News, a mysterious heart damage, not just pulmonary. And from Scientific America, heart damage in COVID-19 patients puzzles doctors. So an increasing focus on the cardiovascular system and COVID-19. Next slide, please. So I'm going to basically talk about this nexus along the following way. First of all, demonstrating that patients with cardiovascular disease are more susceptible to COVID-19 than are other patients, and that it results in a more severe infection. Remember, any infection, and certainly one that's as virulent as COVID-19, can decompensate a condition in the cardiovascular system that is quiescent at the moment. There is an amazing focus on the evidence for myocardial injury. We call it myocarditis, but perhaps not in the classic concept of myocarditis. I'll discuss that a bit, and then I'll finish up with a few comments on therapeutics. Next slide. So this slide really just makes the point that any infection can decompensate quiescent heart disease. And you see in the chart on the left that in the initial weeks after an infection, that there's an increasing number of cardiovascular events, worse with pneumonia and sepsis, less with pneumonia and even less with upper respiratory tract infections. But any systemic infection, as you can see in the lower right, can stimulate cytokines, and that's a very important aspect of the pathophysiology of COVID-19, so-called cytokine storm that can create all of the abnormalities you see listed there. Next slide. So let's talk about the fact that cardiovascular disease predisposes to COVID-19. Next slide, please. So here you see some data that went through March of this year, and it looks at underlying conditions among adults hospitalized with COVID-19. And you can see hypertension very, very prominent, and that while not so prominent as an underlying condition in young people, much, much more prominent. Over 70% patients over the age of 65 being hypertensive. And of course, that's the age group that's most susceptible. Interestingly, obesity. Obesity now not only a factor in cardiovascular disease, but in this COVID-19, and moving all the way to the end, cardiovascular disease other than hypertension, again, being nearly 50% prevalent in patients over the age of 65. So clearly, if someone has cardiovascular disease, they're very much at risk for getting this infection. We don't know exactly why, but that's the facts of life. Next slide. This is the most recent data that I was able to glean from the internet just last night. Again, showing the very same data in the United States. And you can see particularly for hypertension, that hypertension is a very significant risk factor. Next slide. So moving on, if you have heart disease and you get COVID-19, does it produce a worse clinical situation? And the answer is clearly yes. Next slide. And you can see here, these are data from China, not from the United States. But if you look where I've outlined a group of conditions in red, and see that in non-survivors, the prevalence of hypertension, more than twice as many hypertensive patients were in the non-survivor group as in the survivors. And coronary artery disease, virtually no one with coronary artery disease failed to survive, but a good number of patients with it did not. So that if you have cardiovascular disease, the COVID-19 infection is worse. Next slide. Again, we move on to myocardial injury. And this is really, I think, what has really increased the focus on the interaction between heart disease and COVID-19. Next slide. So here, an article from JAMA, again from China. It was a single center study of 416 patients, and I'm not going to discuss many specific studies, but this was the first one that was important. They looked at patients who had an elevated troponin, didn't have to be very elevated, just above the 99th percentile. And what they observed in China was that 20% of patients with COVID-19 had an elevated troponin indicative of cardiac injury, because we know troponin is basically in the myocardium. Next slide. Here again, the baseline conditions in those patients who had an elevated troponin. See, they tended to be older. They tended to have chest pain, and interestingly, and kind of predictably, they had a high incidence of underlying cardiovascular disease to begin with. Next slide. So again, data from China demonstrating that evidence of myocardial injury has been present in SARS and in MERS. And in two early publications from China, again, demonstrating myocardial injury. And as you can see, a high percentage of those patients, 5 in Huang study, and a high percentage in the Wang study did not survive. Next slide. Now, the question has been, what's responsible for this myocardial injury? I'm calling it injury rather than myocarditis. And the reason for that is that we really don't have evidence that it's a traditional myocarditis in the sense of the word, with either invasion of an infectious agent, but certainly with lots and lots of inflammation. And I'll show you some of that in a moment. But here's evidence that the myocardium definitely is abnormal in this cardiac MRI scan. From a patient, you can see diffuse increase in intensity in the myocardium, indicative of edema, and demonstrating, although we can't see it here, that there was significant cardiac dysfunction. The ejection fraction reduced from a normal to 35%. Next slide. So troponin represents a significant risk factor here. All of the factors, again from China, associated with death from the COVID-19 infection. And you see the highest odds ratio by a huge factor is elevated troponin. And an elevated troponin had an extraordinary odds ratio for in-hospital death if a patient manifested this abnormality. Next slide. So this slide again demonstrates what I've been telling you about the increased risk of death if there's evidence of myocardial injury. On the left, you can see over a course of days, the survival rate being about half in patients who demonstrated cardiac injury as it is in patients without cardiac injury. And in the upper right, the percent mortality is demonstrated for various degrees of troponin elevation. And this shows quite clearly that the more troponin elevation that is observed, the higher is the mortality. So that there's a clear link between the amount of myocardial disease and the risk of death. Next slide. This slide looks at the combination of having underlying heart disease and an elevated troponin. And you can see that the mortality rate is very, very high, 75%, if someone has underlying cardiovascular disease and an elevated troponin. It's high with an elevated troponin, even in the absence of underlying cardiac disease, there being over 37%, and clearly much worse in those two groups than in groups who have neither underlying heart disease or an elevated troponin. In the lower right, one of the few comments I'll make about arrhythmias, because interestingly enough, in the absence of cardiac involvement, arrhythmias have not been nearly as big a problem as would have been anticipated. However, in patients who have a troponin elevation, serious ventricular arrhythmias were seen in a high percentage of patients, ventricular tach and fibrillation, in 17% of patients, often the cause of death in those patients. Next slide. So the question is, what is this myocardial injury? And initially, every instinct was to say, well, this is good old old-fashioned viral myocarditis. Now, since the disease is so infectious, there haven't been that many cases that have undergone extensive autopsies or myocardial biopsies. But this is about the only case of a myocardial biopsy that's been published in the literature. And as you can see in the lower right, as compared with the lungs where there's tons of inflammatory cells, there's almost no inflammatory cells in the myocardium. So that histologically speaking, in this patient who had evidence of cardiac injury, there was a surprising absence of the standard manifestations of inflammation, suggesting, next slide, that in fact, this is in many patients not a conventional infection. So here's the potential mechanisms that can be responsible. It can be ACE-mediated direct damage from the virus entering the cell, or it can be secondary to hypoxia from the lung injury. These patients become tremendously hypoxic, obviously requiring vents very frequently. It could be due to microvascular disease because there's lots of ACE2 receptors on the vasculature, or it can just be a systemic inflammatory response, a so-called cytokine storm. And increasingly, there's a focus on this cytokine storm, as I'll describe a little bit greater detail in a minute. But lots of cytokines, you can see IL-6, IL-1, JAK inhibitors, moderating the cardiac disease. Next slide, please. So that this is a terribly complex slide, and I'm not going to go through it completely, but on the bottom, you can see that cardiac manifestations can be myocardial infarction, can be heart failure, can be arrhythmia. And the possible mechanisms that can result in any of those conditions are shown on the top. Prominently for heart failure and for arrhythmias, there's a prominent notation for myocarditis, for myocardial injury, whereas for myocardial infarction, other mechanisms such as hypercoagulability or sympathetic stimulation probably play a more important role. Next slide. So what's the take-home message? Well, number one, myocarditis in the general sense, or myocardial injury, is seen very frequently in up to 20% of patients with COVID-19. However, it is not clear at the moment whether this is actually itis, an inflammation of the myocardium, or is related pathophysiologically to some of those other factors such as hypoxia or cytokine storm, so that that an elevated troponin does not equate to myocarditis at this moment. Next slide. All right, turning now to some therapeutics, which of course we're all very, very interested in. And there are a couple of areas in terms of therapeutics where cardiovascular conditions are very important. Next slide. So just looking at this from the standpoint of therapeutics, this represents the majority thinking at the current time, that there's 3 different stages of the COVID-19 condition. First, the viral response phase that occurs very early. That's direct entrance of the virus into cells with destruction of the cells and whatnot. And you go into a secondary stage where traditionally, and to this point in time, primarily the lungs have been involved with a severe respiratory condition. However, there follows a third stage of the illness, which is characterized primarily by a hyperinflammatory response where the body basically is reacting to itself and is systemic, involving not just the lungs, but potentially the heart and the kidneys, et cetera. And this has been termed the Cytokine Storm. It's manifested by ARDS, by SIRS, the systemic inflammatory response, and by cardiac failure. And on the bottom, you can see therapies as they're applied to these various stages. The antivirals, remdesivir, being the most prominent at the moment. There's just data this morning on the internet that there's been some positive results from compassionate use data for this antiviral. Chloroquine and hydroxychloroquine, the antimalarials that have been shown to inhibit to a certain extent the entrance of the virus into the cell, and convalescent plasma transfusions. As there are more and more survivors, people have been getting plasma with high antibody titers to infuse into other patients, so that early on it's reducing immunosuppression. Later, trying to deal with that cytokine storm with corticosteroids, immunoglobulins, et cetera. Next slide, please. So a question that comes up relates to anti-inflammatory agents. Should we take them? If we get a headache, should we stop taking ibuprofen, for instance? And these are all agents that deal with prostaglandins, which themselves may promote inflammation, but also can have beneficial effects. I'll just say on the bottom line that at the moment, there's no evidence that if you're taking anti-inflammatory agents, that you will be more predisposed to COVID-19 or to a serious reaction if you do contract the disease. However, people are looking into this, and there's even some data as to whether they can protect from ARDS if they're given to patients later in the course. Next slide. They've been tried for the cytokine storm without much benefit. Now, the other focus has been, the other focus is on the ACE2 inhibitors, because that's how COVID-19 enters the cell. And the question as to whether ACE inhibitors are detrimental or beneficial. Next slide.
I'd like to just say that Tony DeMaria should be able to go until 12:55, and we'll reduce other time so that you don't have to rush.
I don't have, how long have I been talking? I don't know.
You have, in your 30 minutes, you would have another 6 minutes to go.
All right, well, I'll be done in less than 6 minutes.
Okay, and then maybe we can have questions. Thank you.
Yes, okay. So, I thought about how to present this. You could go into the weeds about the pathophysiology of the interaction between the ACE2 receptor and the virus. And there are clear-cut theoretical considerations where an ACE inhibitor could be detrimental or beneficial. And actually, there's more theoretical considerations for ACE inhibitors being beneficial. And there's some trials going on in patients when they're in that third stage of disease. But this shows the recommendations of all kinds of medical societies, the American Heart Association, American College of Cardiology, European Society, Canadian Society, said every single one of them says that there is no evidence that taking ACE inhibitors predisposes to the disease or makes it worse, and that patients who are taking hypertensive agent, taking ACE inhibitors for hypertension should continue them. And in fact, given the data that patients with hypertension do worse with the disease, and given the data that the worse the hypertension control, the suggestion that the worse patients do, there's important reasons that patients who are controlled on ACE inhibitors should continue to take them at the current time. Next slide. Now, having said that, on a previous conversation that Bill Baumer, Joe, and I had, I pointed out that in a division of cardiology discussion at UC San Diego, the majority of people said, we're keeping our patients on ACE inhibitors. But one of the smartest and most thoughtful cardiology faculty said he disagreed, that first, it was important to do no harm. And if there were other agents that were suitable to treat patients that they weren't already on, that he was stopping ACE inhibitors in all of his patients that fulfilled that criteria and substituted the other agents. And here a statement from a European physician, a cardiologist, said that although the evidence doesn't demonstrate that the ACE inhibitors are bad, neither does it say that they are not adverse. So that there's still that question. I think, thoughtful cardiologists, thoughtful physicians, if they have the option of using other agents, may in fact choose to use those other agents. I have not chosen to change for my own therapy. Next slide. And I think this is going to be my last slide. There's lots of controversy as to the role of chloroquine, hydroxychloroquine, the most available is Plaquenil, used primarily for rheumatic diseases, and azithromycin to combat superinfections. And whether or not these agents are effective, there's some anecdotal data that they are. Just this morning, a trial in Brazil showed if you give high doses, they can have adverse effects. And so the question, should everyone receive these agents? I have patients that have managed to get these agents and are taking them prophylactically. And again, the medical societies have gotten together to condemn the prophylactic use and to point out on the next slide that that in fact both of these agents, azithromycin and chloroquine, can increase the QT interval, and the QT interval, QT prolongation, is a major risk factor for serious and often fatal ventricular arrhythmias. So they've made some recommendations, but I think if any patient is to be given these drugs at the current time, their electrocardiogram has to be monitored closely for QT interval. So last slide, what I've tried to do in more minutes than I thought I would talk is to review these interactions between cardiovascular disease and COVID-19, showing how patients with heart disease are more at risk, that there's an increasing recognition of the importance of myocardial injury, and that several of the cardiovascular therapeutics that we use have been questioned as possibly increasing risk, and several of the drugs that are used can potentially have adverse effects on the heart. That's my presentation.
Thank you so much, Dr. DeMaria. Does anybody have one question that they'd like to pose? Hearing none, we can move on to our next presentation, if that's okay. Dr. DeMaria, will you be staying with us to answer questions later if they come up?
You bet.
Thank you. So we are so blessed today to have some of our leadership also from our Los Angeles region joining us. Dr. Michael Hochman is the director for the Health System Science and Innovation at the Keck School of Medicine at USC, and a graduate of Harvard Medical School. I won't read this to you, but he also has been a very important advisor to the Los Angeles Board of Supervisors. And with that, let's move to the next slide so that Dr. Hochman can start his presentation. Thank you, Mike, for being with us.
Sure. Thank you very much. And thank you, Dr. DeMaria. That was really a fabulous, very interesting discussion. I learned a lot. Tough to follow in those footsteps, but I will do the best I can. Okay, so I'm going to spend a little time talking about, as Hattie said, I direct the Gare Center for Health System Science at the Keck School of Medicine. So we've been working with our own health system here, Keck Medicine of USC, as well as a couple community partners who you'll hear from shortly. And I can sort of talk about some general lessons learned about health system approaches throughout this COVID-19 pandemic so far, and specifically some of the things we've been doing here at Keck. Really hope to use this just as a conversation starter. Many of you probably have done similar things, and we can compare notes in the question and answer session. Next slide. Okay, so that's just our agenda, what I just described. Next slide, please. I just wanted to acknowledge the two people who make the work that we do possible. First, Mr. Norbert Gare, who left money to support the Gare Center, and then David Goldstein, who was the founder of it and hired me to be the director. Next slide, please. Okay, so I couldn't decide exactly how to organize this discussion. So rather than trying to be systematic about it, I sort of picked out some interesting topics that have emerged here at USC. And I just thought I would mention how we've addressed them, and people can then in the question time ask questions, explain how they've done it, disagree with how we've done it. Now, one interesting question that I know we are not alone in struggling with is how exactly does SARS-CoV-2 spread? We certainly know it spreads through those respiratory droplets that much like flu that carry 6 feet, but there's a question, does it aerosolize and spread farther than that? In which case patients would ideally have negative pressure rooms and N95 masks. Now, of course, if that's the case, there is no imaginable way that any health system is going to have enough negative pressure rooms to care for them. So the CDC, the WHO still recommend and believe that droplet transmission is the key mechanism. However, you probably have heard of many healthcare workers. There were a number here at USC who were really advocating very hard for the N95 masks and the negative pressure rooms. It does seem, though, that droplet spread is the main way, and that's what we are settling on. Next slide. So even if there is some longer spread, aerosolized spread, that some of the most important things we need to do are deep cleaning because the virus lives on surfaces. So we've really tried to ramp up our cleaning protocols between patient visits. Another key thing, it probably is very valuable for both the patient and the provider to wear a mask because, many of you know this, but the main reason to wear a surgical mask is not to protect yourself from infection, but to protect the droplets from being released, to protect others. So we have really tried to emphasize, and it's not easy to do, to ask patients who are being admitted with respiratory discomfort to put on a mask, but that is something we are trying to do to protect our work environment. Next slide. And then the N95s for aerosolizing procedures. And I'm going to go through a couple of these relatively quickly because we have very good speakers and I'd rather use our time for some of the question and answer session. Next slide. We've had some interesting and colorful discussions about how to handle high-risk employees, those 65 and older, those with chronic conditions that put them at increased risk of COVID-related complications, a number of pregnant healthcare workers. We have gone the path of encouraging such folks to work home, work remotely, contribute to the USC mission in other ways, but we haven't put a hard stop in those categories who do want to work from being those frontline workers, of course, with the understanding that they wear appropriate protective equipment as is recommended. Next slide. This is just our triage system. Like many of you, we've tried to shift to a teletriage telephone approach where patients with mild and even mild to moderate illness, we try to evaluate as much as possible remotely. Those with moderate or severe symptoms, we have a tent set up where you can be evaluated and then admitted to the hospital if need be for severe illness. Next slide. This is a very brief slide to show there was a nice, interesting article in AARP about Keck Medicine of USC and the increase in telemedicine work. If anyone wants to check it out, there's an accompanying video. Next slide. And I think this slide really says it all. So this is a graph showing and thanks to Carol Peden, who's one of the co-chairs of Right Care, for putting this together, one of our good colleagues here at Keck. This is a graph showing the uptake in, I should say, in telemedicine clinics, or clinics using telemedicine equipment here at Keck since COVID began to spread. Next slide. And this is the number of completed televisits per day. Went from just hovering around a couple dozen a week, or a day, I should say, to several hundred a day. In March, we did almost 3,000 televisits. And Carol Peden has a case report that she's working on to just add that to the literature. I'm sure it's consistent with what many other health systems are experiencing. I think one thing we're fortunate is that we did have a foundation for doing televisits and telemedicine here at Keck. We didn't have the reimbursement structure to support it, which is why our rates were so low for the past year and a half, 2 years, despite the fact that so many of us wanted to do more telemedicine. But this was the opportunity, and we were ready to jump on it when it arose. And hopefully it will continue when things settle down with COVID. Next slide. Okay, so these are the patient satisfaction survey results. We do a brief patient survey at the end of these televisits, and this is for both primary care and specialty care visits. Now, one thing is that we don't have benchmarks for what these numbers should be for telemedicine. As many of you know, for the traditional CAP surveys, a score of upper 80s or 90s is really what's needed to be considered good. So although the majority of patients responded favorably to our survey questions, I'm not ready quite yet to say that we're doing everything perfectly and we're satisfied with how we're doing. We obviously want to know what benchmarks are, but responses here, I would point out 83% of patients said I would recommend virtual visits to friends and family, which I think is very telling for the post-COVID world. And the other one, I would like to use virtual visits for other types of care, 77%. So we all know, obviously, televisits have an important role for care during the COVID outbreak, but I think there's going to be a much bigger role for it beyond that. Next slide. Okay, well, testing has been a moving target because everyone knows, of course, there's been a real shortage of supplies. So we've tried to prioritize tests for those patients who are critically ill in the hospital. For most ambulatory patients, the test doesn't really change management, which is just supportive care. Next slide. And we've sort of thought about it this way. There's therapeutic purposes for testing, if you could advance that. And really the only situation where that's helpful is for critically ill patients. It's helpful to know if someone's in the ICU, if it's a bacterial pneumonia you're dealing with, or with
10 minutes.
COVID. Thank you. And then there's public health purposes, which are going to become more and more important as tests become available and we start to, at whatever pace it ends up happening, reopening the economy so that we can do contact tracing and isolate those who are positive or have had direct interactions with someone who is positive. I think some of the really interesting work about digital contact tracing, there was the Apple and Google tool. I know a number of other innovative groups are putting out apps that are going to allow us to have digital tools to support community health workers with these contact tracing efforts. I'm just reading a question here. Do you know if the rate of declining televisits by age? You know what, I'm going to get to these questions at the end. Sorry, but I'm just starting to see them pop up in front of me. Okay, if you could advance to the next slide. Okay, so this is sort of a tongue-in-cheek slide. The evidence-based treatments for COVID right now were fluids, Tylenol, and rest. Like any viral illness, are really the only evidence-based things we could do. Next slide. In ICU care, there is not rigorously proven through randomized trials, but emerging powerful evidence that prone positioning, having patients in the prone position, lying on their stomachs, is an effective strategy, especially with ARDS, those who develop ARDS-like picture. Next slide. So we've had some very interesting discussions about how we think about new therapeutics. There's, as everyone knows, a lot of different drugs that are being pitched. And so we came up with some principles as an organization that are posted on our website. It says, while there's pressure to fast track the evaluation of COVID-19 treatment, adherence to rigorous scientific methods to evaluate therapies remains just as critical as ever to avoid unintended consequences. Taking shortcuts in the evaluation of new therapies may lead to widespread use of ineffective treatments with associated safety concerns. I think the hydroxychloroquine discussion that many of you are familiar with is a classic example of this. While many of us are hopeful that this will work and some of our clinicians are using it, it does have emergency FDA approval. There are also some potential side effects, including cardiac side effects. So it really does need to be evaluated in a rigorous way and an expedient way as well. Next slide. Okay, this is a similar statement that we put on our website about right to try policies. History teaches us that in many times these right to try untested treatments leads to more harm than good, and we really are encouraging as much as possible to test experimental settings and use them in a research setting so we can learn in the process. Next slide. And as I mentioned, this is just a statement we put up specifically about hydroxychloroquine, acknowledging that there are some promising small randomized trials, also some negative randomized trials. We just, under typical circumstances and even under the current circumstances, current evidence is not sufficient to support this therapy, but we're all watching and listening closely for the updates. Next slide. I'm just going to commend an article by Sunita Puri in the New York Times. She's a colleague of ours here at Keck who just wrote about the importance of having these difficult end-of-life decisions. Now, unfortunately, COVID is pushing some of these decisions up faster than many of us were expecting. So if anyone has a chance, I would really recommend that op-ed piece she wrote. Next slide. We've also been thinking very carefully about the easing of social distancing restrictions. USC is actually the largest private employer in LA County. So some of the decisions we make about when it's safe to resume classes, laboratory work, clinical work for routine care will have important implications for others. We've been discussing internally some of the suppress and lift policies where we bring people back but be prepared at any second to close things down, targeted approaches where we protect the highest risk patients, and then of course the antibody and immunologic testing where certain people would be able to, who have already had the infection and are no longer susceptible, assuming that that immunity proves true, which is still being established, that you'd be able to.
5 minutes.
Next slide. So I mentioned before contact tracing. This is a statement that the LA County Department of Public Health put out, that it really is the responsibility of the healthcare delivery systems to help the department contact tracing and notifying those who have been in direct contact with someone who is positive. My point here is just this is going to take a frame shift in how we think about our responsibilities. It's also about the public good, not just about the individual patient in front of us. And I think we could really benefit a lot from some digital tools to help with this, and also some volunteers. I'm aware of many students and volunteer organizations that want to do some of this support with contact to notifying people who have been exposed and checking in and following up on people who are positive. Next slide. I talked about digital contact tracing already, so next slide. And I just wanted to close by talking about two specific things that we're doing that others might benefit from. As I mentioned before, we've put a number of statements about principles and treatments on our website. It's right here on our Keck School of Medicine coronavirus page. It's that gold bar at the top. We call it the Keck School of Medicine Evidence-Based COVID-19 Summary. We have a number of different authors that write we keep it updated at least a couple times a week about different topics on COVID-19. So if someone's looking for a sort of an all-in-one resource, check it out. Next slide. And that's just the website, keck.usc coronavirus. Next slide. And then I also just wanted to briefly mention a tool that the GARE Center has been making in partnership with Ultimed. You'll see Ultimed there and an IT partner, Keto Labs. We developed, it's now available in English, Spanish, and Portuguese, a patient self-assessment tool. So just a very simple thing. We're by far not the only one that has done this, but we were one of the first to get it out there. And it's available at covidassessment.org. It's freely available. You can send it out to your patients. And it just really guides people about whether or not they need formal medical attention. And if not, what are the home self-care instructions that they can do, which are, again, the simple things: rest, fluids, Tylenol. Next slide. And this is just some data about where it's been used. So we've had about 22,000 users in the LA area, about another 17,000 in New York. We've had about 360,000 unique users worldwide in 200 countries. Next slide. And this is actually, I think, one of the more interesting slides. It's the distribution of those 360,000 people. The vast majority of them, more than half, had only mild symptoms. About a third had no symptoms. And it was really only about 13 or 15% that had more severe symptoms that required direct medical attention. So again, this just highlights that the American public is open to using some of these digital self-assessment tools to get some initial guidance, and B, that many patients with respiratory illnesses don't necessarily need formal medical attention, and there may be ways to limit the burden on our healthcare system and triage those who really do need a formal consultation. Next slide. And that is it. And I guess there are a few questions I see here. Maybe we ought to do those all together with the panel, with the other panelists. Hattie?
Why don't you go ahead and answer one question of your choice and then introduce the next speaker?
All right, very good. So this question I have right here at the top, do you know the rate of declining televisits by age cohorts in your clinics? And do you have any information by specialties? I should have picked a question that I knew the answer to. I don't know. I can say from personal experience that some of my most rewarding calls have been with older patients. Often it has been with a younger family member or neighbor helping them. Again, just personal experience. There have been a couple of frail elderly patients who I felt really good about by talking things through with them, prescribing, a steroid or, telling them to use some Pedialyte. I think we've been able to avoid having them come into the hospital or urgent care setting. I'm sure there are plenty that I'm not seeing who are not able to get on due to the technologic barriers. I will say that Keck will see you even if you cannot do the video conference. You don't have the right computer equipment, internet access, and we'll do a phone visit with you instead. It's not we don't get reimbursed anywhere near the same amount, so it's hard, a little bit a challenge on the financial side, but we've made that telephone option available for people who can't do video visits. And then I believe, Hattie, the next speaker is Steve Chen. Is that correct?
That's right. He's one of your key innovations that we were talking about.
Perfect. And actually one that I didn't get to talk about, and Steve is a really easy person to introduce. So Steve is the Associate Dean for Clinical Affairs here at the USC School of Pharmacy. He has been, I don't think it's an exaggeration to say, the national leader in thinking about advanced practice clinical pharmacists. He's always the guy on the Institute of Medicine panels, representing the pharmacy discipline in these discussions. He was a co-PI of a $12 million research project in partnership with Ultimed. We're fortunate to have an Ultimed representative in today's session that will be talking soon. And I think there's an incredible opportunity during this COVID-19 pandemic to take advantage of clinical pharmacists who have closer interactions with patients than many of us medical providers, because patients do need to physically go into the pharmacies to pick up their medications. And so some of these things that Steve has been talking about, comprehensive medication and management, collaborative practice agreements, are more important than ever, not just with the chronic diseases, but also with COVID-19. So with that, let me turn it over to you, Steve.
Mike, thanks so much for that introduction. And Mike is one of many collaborators that have enabled this work to help pharmacists make a difference in healthcare. Next slide, please. So I just wanted to clarify that what you're going to be hearing is published at a sort of higher level this morning in the conversation. If you look up my name and I guess School of Pharmacy, you should find this piece that's come out. The funny thing is this op-ed took 2 weeks to write, and I rewrote it about 7 times. I think that reflects the influx of data that's coming in constantly. So my disclaimer for today's presentation is anything that I mentioned related to COVID is good until the end of the presentation. And then for the rest of the day, I'm sure several facts will change. New data comes in, new policy, politics, et cetera. So again, that's my disclaimer. Next slide, please. So I was talking to Hattie about a month ago or so, maybe a little more, about what was happening, what was coming down, and with COVID, this healthcare system that's straining so much already, that is delivering healthcare quality across the board that could be much better, which is why Right Care exists. And we were talking about how, well, not only do we need to get on top of testing for this virus, but we need to make sure that our patients with uncontrolled chronic disease get the care they need. And anytime you have a conversation with Hattie longer than 15 minutes, she's going to voluntold you to do something. So she voluntold me to give this presentation today. Next slide, please. And I'm going to be focusing on vital roles for pharmacy in light of this current pandemic. And they're going to be centered on community containment and improving chronic disease control. And I think everything that was said before from Dr. Baumers to Dr. DeMaria's, Dr. Hochman nicely set up this part of the presentation. Next slide, please. So you don't need to be an outbreak scientist to know, and next slide, please, that one of the keys to containing the size of an outbreak is to quickly identify cases using rapid diagnostic tests and accordingly manage and quarantine those patients. This is based on this report, which refers back to some of the more recent epidemics like SARS and MERS. Next slide, please. And what they're really referring to is flattening the curve, which we've heard a lot about. Now, the funny thing about this diagram is it's referred to as the hammer, the quick flattening of the curve. It's not 3 to 7 weeks. Depending on where you live, it could be a lot longer, unfortunately, and that's because probably didn't get on top of this early enough. I might get fired for saying that, just like Anthony Fauci. Next slide, please. But for countries that did indeed quickly develop tests, quickly implement them, and accordingly quickly contain patients and conduct tracing, you can see that mortality rates were significantly lower. We're talking about South Korea, Germany, Singapore could be in that mix. So I read somewhere that you may be able to hide cases, but you can't hide deaths. And here we're showing that deaths are significantly reduced when you can get on with early testing and early action. Next slide, please. Unfortunately, we weren't quite that early enough, and as a result, as we all know, our hospitals, our ERs are overwhelmed with the patients that are coming in. Next slide, please. And unfortunately, as sick patients come in, they infect healthcare workers. Our healthcare workers are now out and quarantine themselves, and worse, in some cases, unfortunately, have been forced to go to ICU, and some have passed away, unfortunately. Next slide, please. And then what Hattie and I were talking about is, this is obviously a terrible thing, but now you have patients who don't have COVID, who are acutely ill and need help. Are they going to get care? They're worried. Is there space for me in the hospitals? If I go, am I going to get infected? It's really a frightening time. And sort of the bottom line is, what we really need is a network of healthcare professionals out in the community where patients live that can be that first line where patients can get screened, can get advised, and so on. And next slide, please. And there happens to be that, right? There's sort of an unleveraged opportunity to engage the 67,000 pharmacies in the United States. Basically, 90% of the U.S. population lives within 5 miles of a pharmacy. And in fact, in urban areas, it's more like within 1.8 miles of a pharmacy. And next slide, please. To give some context to that, there are 5,500 hospitals, 5,400 emergency rooms, and 1,400 community health centers. And it is even hard to understand what that really means. So next slide, please. Maybe for some of you, this helps. There are 15,000 Starbucks in the U.S., so there's basically 4 times more pharmacies than Starbucks. I hear a collective ah across California, so I think that must have worked. Next slide, please. So as I was preparing both this presentation and the op-ed, my primary focus was to make the argument that pharmacists need to be authorized to order and administer COVID-19 testing. And then up until last week, it was a good direction until the Health and Human Services indeed did authorize pharmacists to order and administer COVID-19 tests. Great news. So if you didn't know this, in many states, including California, pharmacists can do in-store flu and strep testing. They can now, under obvious protective circumstances, provide COVID-19 tests. And next slide, please. And what they can do is educate mild to mildly moderate patients on what to do, self-care, as Dr. Hochman had mentioned, quarantine, and if patients come in with more than just mild to moderate symptoms or develop mild to moderate symptoms, they can be referred for appropriate care. Once immunizations are available, pharmacists, as you know, can already provide immunizations in pharmacies. Patients get ready access to that. And then, as was just shared, there are some critical research needs that community pharmacists can engage in. We were contacted by an epidemiologist from the San Francisco area who is proposing to develop a network of pharmacies that could monitor medications in community. So as Dr. DeMaria mentioned, hydroxychloroquine and azithromycin, both independently, can prolong QT intervals. We have a small proposal into the AHA to monitor azithromycin and hydroxychloroquine use using the cardiomobile fixed-lead point-of-care testing device from AliveCor. AliveCor is on board. They're excited about it. We're hoping that could take off. But there are other opportunities to do other physiologic measures to ensure that medications are given only when safe and appropriate, and then monitored carefully for patients at high risk. There's also the need to understand serologic testing. We know that it's becoming available. In fact, one of our board members for the School of Pharmacy owns a very reputable company that is developing those, and we're in the process of developing a project that will engage several of the leaders in this call to figure out what does it really mean when you have an IgG, IgM, IgA present. Does it infer full, partial immunity? How long does it last? A lot of questions that haven't been answered that we hope to answer by working with our board member. Obviously, there's data tracking for public health purposes. And then there's that ongoing piece that happens after the flattening of the curve, the testing, tracing, and quarantine cycle. Next slide, please. And so I'm sorry, one more slide, please. And what I'm referring to here is sometimes called the dance. So again, the hammer was flattening that curve out. The dance is the cycle of testing, tracing, quarantining, isolating, and then restricting or removing restrictions as needed, sort of the dance part of it, to bring people back outside, bring the economy back, and so on. Next slide, please. One of the questions in that process is, how many tests do we have to do a day in order to ensure that patients are well monitored and relatively safe to be out? I don't think anyone really has the answer, but Harvard last week published this white paper, and in it, next slide please, they conclude, based on a number of assumptions, that it's going to take tens of millions of tests a day to let people back outside. I've not heard that number really many other places. I've heard under 1 million a day, but if you look at their models, and they're quite conservative, they're suggesting that tens of millions of tests a day are going to be needed at a cost of tens to hundreds of billions of dollars. And this would require use of intelligent tracing, as Dr. Hochman had mentioned. But at the end of the day, they're saying this offsets the daily losses that the U.S. economy is taking a hit on right now. Next slide, please. And when we talk about intelligent tracing, one of the examples they share is out of Singapore, where they do what's called precise tracing, as opposed to imprecise. Imprecise tracing would be using GPS, for example. So if a patient is identified who's got a tracker on their phone using GPS technology, there's sort of a general call out to anybody in these areas where the patient was to recommending they get tested. That's imprecise tracing. You all know, if you've tried to use a GPS device to walk somewhere, how sometimes you start walking in circles and aren't sure which way to go. With Bluetooth, these connect phones to phones. So now instead, if an individual tests positive, any phone that came in contact with this individual would get a message saying, you've been identified as being within a certain distance of an individual who's tested positive, you should get tested as well, something like that. Next slide, please. The concern about the one out of Singapore, which is what this Trace Together is from, is that it doesn't really maintain privacy very well. So just last Friday, Apple and Google committed to partnering together to develop a contact tracing technology that's Bluetooth-based, so it's precise tracing, fully interoperable between iPhones and Android phones, and they have on their website very specific details on how they would preserve privacy of the users. So it could be something that works well here, where privacy is highly regarded in the US. Next slide, please. So that sort of sums up the picture of how community containment could look involving pharmacists. On to the next slide, please. What we'll talk about now is improving chronic disease control. And next slide. Dr. DeMaria and I, over the weekend, were looking at the same article, so thank you for covering all of that. What I'll point out, which I think he's already said very well, is there are questions about, if you have a patient with hypertension and it's relatively mild and well controlled, is that person at greater risk for either hospitalization or mortality? And although that is an interesting question that at some point I'm sure will be answered, I think what we're seeing is these patients are all older, or not all, mostly older, have multiple comorbidities, and are very frail because they have hypertension, and they're obese, and they have diabetes, and they have cardiovascular disease or at very high risk, and they might also have COPD. It really describes a very typical patient that I've worked with in the course of my career. Next slide, please. Which has been the provision of comprehensive medication management. Comprehensive medication management is perfectly aligned with these high-risk patients that we're concerned about with COVID, and for that matter, anybody with uncontrolled chronic disease. Next slide, please. The standard of care that ensures the right medication is chosen, given that there are obviously many choices out there, but the optimal medication based on evidence. Next slide, please. That the right dose is given for that patient to make sure the patient is therapeutic, not toxic, not subtherapeutic. Next slide, please. That the treatment is safe given other comorbidities, other medications, no contraindications or drug interactions. Next slide, please. And that the patient can use the device and the medications as directed. Next slide, please. As well as ensuring that the medication is affordable and accessible. These are all critical components of comprehensive medication management. Next slide, please. I don't have time to go over all the evidence of how this works or how well it works for the various common chronic diseases, but bless Hattie for commissioning this pharmacist on the care team patient safety and savings brief, which she gave me a chance to contribute to. In it, you will see some of the biggest trials, biggest studies indicating the value of comprehensive medication management that aligns with quadruple aim measures, better access to care for patients, and many of which have a sustainable value-based payment model associated with it. They include diabetes, hypertension, et cetera. Next slide, please. Now, most of you that are familiar with pharmacists on the care team have worked with or seen pharmacists working in hospital-based clinics and in patient-centered medical homes. Next slide, please. But we've had for a number of years pharmacists providing these services remotely, either by video telehealth or phone telehealth. That's obviously escalated during this current pandemic. Next slide, please. But what we're zeroing on is trying to empower that community pharmacist to be that untapped resource in the community, to be an access point for healthcare, as well as a point where the patients can receive comprehensive medication management and some of the preventative services that we just spoke about. Next slide, please. So the California Right Meds Collaborative was founded with that purpose in mind, the mission of which is to provide optimal medication therapy for high-risk patients within their communities. Next slide. I'm not going to go over this in great detail, but basically it's a collaborative that enrolls selective pharmacies who are vetted by a very stringent process in partnership between the health plans and our school. There is our live learning sessions, which currently are, of course, remote, that occur twice a year. We have very frequent webinars. Lately, we've had webinars twice a month, if not more frequently, to ensure that our teams are well-trained and capable of delivering high-value care. We have action periods between our training sessions. We have coaches assigned to these pharmacies. And more recently, because of the pandemic, we have launched virtual care training, both phone and video telehealth. Next slide, please. And so you can go ahead and build this slide up. I didn't realize the build slide. My apologies. Oh, wow. Okay. Never mind. I guess the text is. Can you go back again, please? Previous slide. Okay. So I don't know what happened to the text, but I'll tell you what it said. So basically, we shared with our pharmacists and pharmacies in the collaborative the best practices we've learned from our work with Dr. Hockman at Ultimate Health Services, delivering video telehealth care from our site to clinics, not directly to home, but enrolling a Medi-Cal high-risk population, so lots of diabetes, hypertension, dyslipidemia, et cetera, as well as our best practices for working with Keck Medical Center of USC on a video telehealth service that went directly from USC to patients' homes, primarily for high-risk heart failure patients. And in both of those services, we were able to generate very strong evidence of value for those services. Next slide, please. So what makes it work? It really starts with the people. So next slide. My team, thankful to all of them, the amazing group of people that I get to work with here at USC. I don't have time to read all their names, but here they are. Next slide, please. And then these health plan partners, incredible innovators, willing to step outside of the box and come up with some very creative and effective value-based payment models, including for video telehealth most recently. Next slide, please. These people I'll call the innovators, the innovators and the people that break grounds where no one has gone before. They've been instrumental in pushing our work forward from quality improvement to expanding to mental health. Next slide, please. And then it's really founded with many of the amazing people on this call, the leaders from local, state to national government that have just been not just inspirational, have opened doors for us to make all this work. Next slide, please. So more concretely, as I mentioned before, what makes our collaborative work well is, frankly, we're not allowing just any pharmacy to do this. I mean, we want every pharmacy to do it, but we're vetting them very stringently for their structure and be able to support comprehensive medication management, their staffing, their resources, evidence of value that the health plan has in terms of their quality of work. Next slide, please. As I mentioned before, the plans have put together very, very creative and very, motivating value-based payment models that just, in brief, pharmacies can get paid up to over $1,000 per patient if that patient reaches treatment goal. Next slide, please. Very thankful to Dr. Tony Kuo and his team for being able to partner on their CDC 1817 grant, which funds the work here in Los Angeles. Next slide, please. With it, we were able to develop a HIPAA-compliant clinical documentation platform that can be shared across pharmacies to aggregate our results, our clinical quality results, and drive CQI. Next slide, please. And then we've had a number of opportunities to perform community-based work that helps inform what we did in this collaborative. We were fortunate to work with the late Dr. Ron Victor in the early phases of his barbershop project and learn his incredibly effective QI process. And then about 15 years ago plus, we had a program with Blue Cross sharing in community pharmacies where we were able to dramatically reduce ER visits, hospitalizations, and costs 70–80% across the board for patients that receive pharmacist care. Next slide, please. So in a kind of a word picture, the health plans, next slide, are identifying and stratifying patients from high to low risk. Next slide. We are together curating this network of pharmacies to deliver this care, training them, selecting them, training them, coaching them. Next slide, please. High-risk patients are being sent to those pharmacies for comprehensive medication management. Next slide, please. And several schools across the state have stepped up and said, we would love to be a part of this. And our goal is to align them with pharmacies geographically proximal to them for closer coaching and assistance. Next slide, please. So in summary, the 2 points that I wanted to make about pharmacy and COVID-19 is community pharmacies, widely available, 4 times more than Starbucks, can be actively involved in the hammer portion of this, can be actively involved in facilitating research needs, and in probably the bigger battle for us for the next 12, 18 plus months, the ongoing dance part of the ongoing testing, tracing, and quarantining in order for us to get back to our work and our economy to pick up again. Next slide, please. And the other aspect is comprehensive medication management. Again, overwhelmed healthcare system, patients with plenty of need, and these patients need to be as healthy as possible who are at very high risk for coronavirus-related hospitalization and death. Next slide, please. So just a reminder, the Surgeon General has said it's a good idea to cover your faces. Homemade face masks are just fine. Next slide. Be creative. Anything can work. Next slide, please. Minimize leak as much as possible. Next slide, please. And if you're hoarding toilet paper, please don't. If you really need that much toilet paper, you probably should have seen a doctor before the COVID-19 crisis. Next slide, please. But if you have extra, you might want to consider giving your mother a bouquet of toilet paper instead of flowers. You'll become the favorite child on her list. Next slide. And the last reminder is, although Chick-fil-A could probably run testing amazingly, next slide, please. there's less than 2,500 locations. So basically, pharmacy is going to try to become the Chick-fil-A of testing for coronavirus. And with that, I'm done. Thank you. Hattie, do you want me to take any questions, or do you want me to wait?
Let's see where we are on time. I think
we're
that
right
you
on
could
time.
take a couple of questions, but then move on to the community perspectives, if you would. So you and Mike invited, Dr. Hockman invited a few folks, including Tony Kuo, who I believe is still on the line. So we'll want to move to that section fairly quickly.
Okay. So I'll just zip through a few of
Steve,
these.
I had
Oh, go ahead.
quick question for you, and that came in, and it was related to great for your televideo conferencing and everything else. Are pharmacists able to bill, and how do you bill for that when you do not, for two things: one, a in-person contact in the pharmacy, and two, if you do a video presentation or contact with a patient, are you able to bill for that, and what codes do you use?
Okay, great questions. So federally, we still are not allowed or not recognized as billable providers for telehealth, nor as providers, period. So we don't use any federal process for that. Within our collaborative, I'm sorry I wasn't clear about this, we have two health plans, Inland Empire Health Plan and LA Care. LA Care is authorizing payment for those visits, whether they're in person or by video telehealth. The way they're doing it is they're running it through kind of their PBM in a way, which they're being very creative about. But the bottom line is they can authorize this payment separate from any other restrictions federally, since they're the managed care plan for Medi-Cal in Los Angeles. I'll just take one other quick question. What tests can a pharmacist administer? According to the guidance from the Health and Human Services, it's both the RNA test for the virus itself as well as the serologic test. So it's both. I think you said two questions, Hattie. I'll write for the rest of them, but let's, guess we'll go on, and I'll hand this back to Dr. Hockman to moderate the Community Perspectives team. Thank you.
Great. Well, great presentation, Steve. So we have a really nice panel, three of my favorite people to introduce you to. So let me jump right in with their introductions. First is Tony Kuo, who directs the Division of Chronic Disease Injury Prevention in Los Angeles County Department of Public Health. He also serves as the director of the Office of Senior Health for the County of Los Angeles. He received his medical degree from the University of Utah School of Medicine, his master's in health services from the University of California, Los Angeles, Fielding School of Public Health. He's board certified in family medicine, and he does have an appointment at the UCLA Fielding School of Public Health in addition to his role with the LA County Department of Public Health. He's really been a huge innovator in chronic disease management, in the safety net, and I'm sure has a lot of very great ideas and thoughtful ideas about the COVID-19 situation. The next person on the panel, I'll just do introductions of everybody and then you can go directly into the next panelist. Dr. Ilan Shapiro is the Medical Director of Health Education and Wellness for Altamed Health Services. Altamed, as many of you know, is the largest independent community health center, certainly in California, and it goes back and forth between being the largest in the nation. He's been a really great communicator in the Latino community, both during the COVID-19 pandemic and prior to that. He's frequently on Telemundo, quoted in La Opinion. He's served as a medical advisor for the General Consulate of Mexico, a member of the editorial board for A Tu Salud, a health bulletin representing Hispanic health topics and resources. He's part of the National Hispanic Medical Association and spokesperson for the American Academy of Pediatrics. Really great, interesting guy, and I know has been doing a lot of work with our team, has been a big partner for our COVID self-assessment tool that I mentioned before. And then finally, another really good person who's kind of new to the LA leadership circles because he just finished his residency training here at LA County USC about a year ago and has already stepped into a big leadership role, chairing CareMore Health System's COVID-19 Coronavirus Task Force, which is a really impressive responsibility for someone who's just a year out of training. He's a practicing general internist and a regional leader at CareMore. For those of you not familiar with CareMore, it's a really innovative and creative Medicare Advantage plan that focuses on frail elderly. So I think that's going to be a really interesting perspective he gives dealing with that vulnerable population during this COVID-19 situation. He did his medical training here at Keck School of Medicine, which is how I know him, of course, and his residency training at LA County USC. And I'm also very happy to say he has been our CareMore Care Center Fellow for the last year, where he spends 20% of his time doing health system related projects in partnership with Care Center and CareMore. So with that, let me turn it over first to start with you, Tony, to kick things off.
Okay, great. Thank you, Mike. Everybody can hear me, I hope. As Mike had mentioned, I actually work for the health department in addition to for UCLA, the other school on the other side of town. We've been tracking the COVID, and I'm just going to provide some perspective from the sort of health department and from the research needs side. We've been tracking COVID-19, of course, for the past, since it started. And locally, as you know, as of today, there's at least more than 9,000, laboratory confirmed cases of COVID-19 in LA County alone, and we're about to reach 300 deaths. The thing about COVID-19 is we've been sort of tracking and looking at what's also going on in other countries and elsewhere within our own country. It's as a lot of the previous speakers have mentioned, chronic disease actually plays a very big role. We know that a lot of the chronic conditions like hypertension, cardiovascular disease, people with COPD, people with end-stage renal diseases, they were the one that ended up having the highest risk of mortality. And so there is a lot to be said about trying to manage chronic disease as also part of the response to the COVID-19 situation. Not too long ago, about a week or two ago, I had talked to Steve Chen, and I had said, yeah, it's too bad the collaborative with the pharmacists we weren't a little bit further or more mature, because certainly comprehensive medication management could have been and could still become a very important, could have a very important role as we move forward with the COVID-19 response. As Steve also mentioned in his slide, I think from my perspective, I think even as we're sort of in the middle of monitoring the potential surge for COVID-19 cases, there's already a lot of discussion and thinking around what's next in terms of recovery, and what we need to do, and what are the parameters in which we can actually relax some of the mitigation measures. And as Steve mentioned, the dance is in some ways one of the key pieces, the idea of testing, intelligent tracing, and then quarantine and isolating. And it sounds a lot harder than it might appear to be, because I think in order to do that, the health department, the health systems, in some ways we're going to have to come up with teams and people with the right type of skill set and right type of training to be able to do that well. And so those are some of the things to consider. And then finally, the one thing I will put forth is that there are still a lot of research needs around implementation of these various strategies that I think remains unknown. There's still not enough testing going around. There's things around household transmission that probably still need some further studying, and definitely studies on social distancing measures and the way the most effective ways of implementing them, especially as some of these mitigation measures get lifted and we're trying to transition back to opening up the economy and transitioning back to a more normal situation down the line. So I'll stop there. Thanks, Mike.
Great. I think Elon is up next.
Gladly, Michael. I actually, if you can, that's amazing. Next, please. I have no financial disclosure. Next, please, Michael. That's my new boss. That's my daughter. There's no social pressure for her to be a doctor at all. Next, please. And I want to share my entire team over there, who's actually the ones that inspire me to do the stuff that we're doing every day. Next, please. One of the things that we're doing here in AltaMed is we're seeing a lot of the interesting things in the community. Then we have been trying to bring the technology, the ideas, and the innovation actually to the underserved communities. And it has been a struggle at the beginning because if we have all these resources for day-to-day diabetes care and we have resources for chronic care, right now imagine that we have a new disease that it's, nobody actually understands anything about it. There's, we need to translate information, we need to make it culturally relevant, and we need to actually put it in the hands of the people that actually can communicate in a better way everything that we're having. And of course, we had something on the community that was quite interesting, that of course that the information is changing most of the times, even though that we're feeling that we have been out there fighting this for 3 years. Sadly, I need to remind everybody that we're going to the 3.5-month mark of the entire thing. Then, and the information is changing so fast that when you actually talk with someone, whatever you promised them last week regarding the masks, the medications, or whatever, maybe this week is changing. Then adapting the expectations that everything is changing, and we will need to have that conversation. And when we know the best advice that we have for you, or for the leader that is out there, or for the physician, or for the entire system, we need to be adaptable and actually be flexible with that point. And the other thing is that we were competing as healthcare providers and healthcare systems with a lot of overload information from the news and social media, and a lot of lies and things that were popping up in WhatsApp, that if you drink like 4.5 gallons of chlorine, you will be clean from the inside out. Of course, you will be clean inside out, and you will not have coronavirus because you will have poisoning for all this stuff. Then that things were the ones that we were seeing on the clinics and the outside part on what do we need to do. And the other thing that we had was to change the capacity that we have and increase capacity in telehealth, in things that we can actually continue serving as a fair qualified health center to the community in a fast and efficient way to make sure that we're taking care of the coronavirus patients, yes, but importantly, diabetes doesn't stop. Asthma doesn't stop. Your COPD will continue. If you have all this stuff that need to be taken care of, are very important. And right now, of course, we are hearing about, being alone in your house. What are you doing as a system for behavioral health? And we started doing a lot of the telehealth things and telehealth, mental health, to make sure that we were not losing that connection. A lot of, most of the patients were very grateful that at least they had that connection. That was one of the things that was truly, truly inspiring to hear the therapists, the physicians, having a different way to communicate. You were actually inside of their house, talking to them in like a new technology, melancholic way of going again back to the basics of seeing the patient at their homes. And that was something that, that we are very, very, enjoying it a lot. I love, when there's times of rapid cycle improvements, knowing Dr. Hockman and his team and all the people from Aikido Lab and trying to push forward initiatives that, they're not perfect and they're learning opportunities and we can all make a difference, and seizing the opportunity as a community center to push that message out there is imperative. one of the things that we were seeing for sure, it's how to protect our own members, our our secretaries, people from back office, front office, and that making sure that they have time to make sure that their families are taken care of in our cafeteria. Apart from making sure that everybody's taken care of, we have actually toilet paper and certain food items that way they can take home in order for them to be safe and for sure taking care of everybody. And of course, I'm very, very motivated to see the positive sign of this. And I see a lot of changes in the way that we're going to be appreciating our patients, the way that we're going to be appreciating telecommute as a physician, the use of new gadgets with old iPhones, old anything, and the way that we're going to be approaching it. And most importantly, how patients will see ER visits in a different way. The way that they're meant to, and maybe we can actually open a tele-ER to reduce those type of visits. Then thank you very much for being here. I'm always open for communications, and of course, one of the things that our mission is to push information to the community in a fast and efficient way. And thank you, Dr. Hockman, for the opportunity.
All right, I think we can move on to Gabe, Dr. Waterman.
Hi, thanks so much. My name is Gabe Waterman. Thanks to all of the Right Care folks for inviting me to Mike for inviting me to be here today. God, what a tremendous group of speakers you all have been, and I've just learned so much today. So it's really great to be here, and thanks for including me. So as Mike mentioned, I'm a physician with CareMore Health, and I'm going to shift gears a little bit, echo kind of Elon's sentiments and talk about COVID from an organizational perspective. And so first, I'm just going to provide you with a little bit of background, and we can go to the next slide, about who we are as an organization. And then I'm going to tell you a story, and it's a little bit of a personal story. It started with me, actually, and that's why I'm here today. Then the next part it entails a cataclysmic event for our organization, which really turned into a call for more dramatic action. And then finally, I'm going to tell you about where we are today. I have a lot of slides, so I'm going to try to breeze through this. I know I'm very short on time. Next slide. So what is CareMore? Next slide. So as Mike mentioned, CareMore is a national integrated healthcare delivery organization. We have several models of care in different markets. In Southern California, we operate mainly as a Medicare Advantage market, taking care of the elderly and the chronically ill. We do have other models in other parts of the country. We have a group retiree solution in Colorado. We also do managed Medicaid in Memphis, Washington, D.C., Sacramento, Dallas-Fort Worth, New York City, and other markets as well. And then this past year, CareMore acquired a company called Aspire Health, which is one of the largest providers of palliative care in the country. And so palliative care is increasingly a really big part of what we do. Next slide. CareMore's business operations are somewhat complex. We do operate brick and mortar clinics, which we call care centers. We employ hospitalists, which manage the acute care. And then we also have a large apparatus called Touch, which manages skilled nursing and assisted living facilities. And then we also operate a large hospital at home program. So we see a lot of folks at home. We can do complex at-risk care at home, utilizing physicians, nurse practitioners, remote telemetry. We can even do some basic procedures in the home. Next slide. So that's about CareMore. That's the background. And now I'll start with my story. Next slide. So how did our organization start preparing for COVID-19? So I'm going to bring us all back to February. And I know that probably seems like an eternity ago for most of you, but I found this compilation of news clips particularly interesting. I think it does a great job of capturing the public sentiment at the time, which is that, in February, coronavirus was not thought to be a significant threat. We heard over and over again, coronavirus is no more dangerous than the flu, and perhaps we should be devoting our resources toward flu mitigation rather than COVID-19 mitigation. Next slide. And that was the exact same sentiment in my company. And I've been following this situation pretty closely, but at CareMore, we had a meeting of all of our physicians. And again, that was what we were told. We were told, let's not focus on COVID-19. It's not a threat yet. And I just didn't take well to that sort of messaging. And so I sent an email to my California chief medical officer with whom I was close. And I just included the introduction to my email saying, hi, Anil, I hope you're well. I'm emailing you because I'm growing more concerned about the COVID-19 epidemic. which increasingly looks like it will become a pandemic in due time. So I sent this email, and within a few short hours, I had gotten a phone call from my CMO of the whole company. And in this email, I called for a series of action steps, including creation of a task force. And he told me, congratulations, you're our new clinical lead for our task force. So next slide. So the very next day, February 25th, we launched our task force, and we had some fairly modest goals. We wanted to educate and train our CareMore providers and affiliated PCPs. We wanted to launch a patient education campaign, secure access to PPE for a hospital, clinic, and mobile-based staff. We wanted to implement new infection control policies, considered masking patients in high-risk markets like Northern California, which is experiencing an outbreak already, in late February, and then developed some staffing contingency plans. And it was a pretty lean task force. We just had our CMO, I was the clinical lead, we had an operations lead, some folks from education and training, and IT and digital health. Next slide. And so about a week later, we had notched some modest accomplishments under our belt. We had implemented universal pre-screening for all of our visits across the enterprise based on respiratory symptoms and recent travel. We had implemented new infection control policies, such as wiping down computer terminals and exam chairs, et cetera, after every patient encounter. We'd started working on procuring PPE on a large scale for the whole enterprise, and we had begun clinical education for our providers. Next slide. And you can see just, I included a screenshot of our screening and triage protocol. And on the right, we developed a web app, which is widely available for all those who are interested. And you can find the link in the PowerPoint, which I think is going to be sent out after the presentation. Next slide. And so the next thing we sought to do is to develop a phase planning document. And as we transition to virtual care, we knew that this was going to strain our resources in the hospital and the clinic in potentially unsafe ways. So we wanted to make sure that our strategic decision-making aligned with our assessment of risk in every particular market. And so we created this very detailed, robust document. It was like 20 pages long, where we had detailed criteria for what constitute low increase versus high risk markets, and then what to do and which sorts of visits should be transitioned to virtual, which sorts of visits should be maintained in person. And level 2 was kind of thought to be the next iteration of this, was where we shifted most non-critical visits to virtual care. And in our high risk markets, we would even consider closing some of our clinics. And this was a pretty significant lift from our organization that we needed. We didn't have all the infrastructure in place. We needed, for instance, our CPs didn't have laptops, so they couldn't work remotely. So if we did need to start shifting to a work from home policy, we were going to have a lot of battles, or a large uphill battle to climb. Next slide. And we're getting really short on time, so I'm going to really breeze through. So a company shaken in the catalyst for fundamental change. So next slide. So on March 25th, our Dallas-Fort Worth, Texas office had an outbreak in their care center. And this just shattered our organization to the core. We had 30 employees who were exposed. We had multiple employees who tested positive with PCR for COVID. We had 2 of our physicians who actually ended up in the hospital. One of them was brought in by ambulance after sustaining a syncopal event. And this just, again, it shattered our organization. We realized that all this detailed phase planning was just not good enough to keep our folks safe and to prevent our employees from being vectors from transmitting to our patients. So if we couldn't keep ourselves safe and we couldn't keep our patients safe, we really needed to reevaluate our operations. Next slide. And so we suspended all in-person care for 2 weeks. That was a really, really big decision that we made. For folks that had critical in-person needs, we would provide exceptions. But as a general rule, we suspended all of our in-person care. Next slide. And so, as I mentioned, we couldn't keep our staff safe, so that's why we did this. Next slide. And so we redefined our goals, which was pretty much the same, but with a new emphasis on refining our PPE protocols and training across the enterprise. PPE was only good enough if you knew how to don and doff it correctly without contaminating yourself. So, and then the other piece that was somewhat new is leveraging data analytics. Next slide. And over the next 2 weeks, we delivered almost 10,000 virtual and telephonic visits. Again, this was a pretty significant accomplishment for us, I think, particularly given some of the IT challenges we faced, as well as the fact that we're dealing with a geriatric patient population, which is not so IT and tech savvy. So We had a lot of help from family members, but we were able to reach, again, 10,000 of our members in less than 2 weeks virtually, and that was something we're really proud of. Next slide. And I'm just going to skip this. This is Atul Gawande's article where he really informs some of our decision making. We did a lot of PPE training across the enterprise. Next slide. This is just some of the analytics work we did, predictive modeling, assessing our financial and inpatient impact. Next slide. And then kind of bringing us up to speed, where are we now? Next slide. So today is actually the day that we resumed our in-person operations, face-to-face operations. And so we have a new dress code for all of our employees. All employees are donning scrubs and rotating lab coats. We have universal screening of our patients and our staff. We're using IR thermometers for all patients and staff in the clinics. Everyone is masked at all times, both patients and staff. Staff, unless they're eating, they are to be masked in the clinics at all times. We restricted visitors from our care centers. This was a really fraught policy, but a really necessary one. And we're doing social distancing in the workplace. All our waiting rooms, we removed chairs. Again, we have new infection control policies as well, and we have a pod staffing model. So we have two distinct teams that never interact with one another. This was something we borrowed again from Atul Gawande's article from Singapore, where many of the hospitals employed two distinct staffing teams, and those teams never interacted. So we've done that as well. Just in case there's another outbreak, we'll still have half our staff. Next slide. Again, this is just walking through exactly what we've done. Next slide. And that's pretty much it. Sorry, I would have loved to talk in a little bit more detail, but I think I had a little bit too much in here. So thanks again for having me. What I can say just in closing is that, I think it's almost 6 weeks to the day that we created our task force. And we've seen our organization just rise in all sorts of interesting and really inspiring ways in a cross-disciplinary fashion. And we've also thought about some really exciting out-of-the-box ideas. We've leveraged an existing meal benefit that we have to establish a new COVID meal benefit for those with food insecurity. And we've delivered 3,000 meals to our at-risk seniors. We've also put together care packages with isolation kits. So they have sandy wipes, masks, alcohol, hand sanitizer, and things like that we can provide our patients when they leave the hospital so that they can isolate at home safely if they don't necessarily need to be admitted. This, again, is really a tribute to the multidisciplinary care and collaborative approach that CareMore took. So that's really, if you have more questions, feel free to ping me offline or in the chat box. And thanks again for having me here today.
Fascinating perspective. Thank you so much. We'd love to have you back for a more thorough presentation sometime. We do have quite a few other perspectives that we might be able to bring online. I know that Dr. Baumer is going to talk about their experience at UC Davis, which has been really, really important. We also have our first co-chair from our San Diego group, Dr. Scott Flynn, who's now with Blue Shield and has been providing frontline urgent care, who's willing to give a perspective. So Dr. Baumer, I'll let you decide. Would you like Dr. Flynn or yourself to go next?
Well, I think that this has been a great discussion and really emphasizes the teamwork that is needed within the healthcare system for all of the team players to get together to treat both chronic disease as well as this pandemic of COVID-19 at this time. So the team approach is very important. The other team that I'm impressed with is the Right Care team, because we have put together, or Hattie has put together with Brian and Megan, a group response from all of the care team sites, San Diego, LA, the Bay Area, and the capital area. And it shows that we really are all on the same team. We're fighting the same chronic disease and deadly virus at the same time. And I think everybody had the opportunity to show all their effort for that. I had a presentation that was on actually the improved testing that we've done up to, we're now able to do our own testing, thousands of cases a day, how our progress on treatment protocols. And I wanted to go over specific treatment protocols if you have a patient in the hospital with COVID-19, as well as our efforts and work on serology so we can test whether you have titers or not, and you'll be safe to go out at that point in time, as well as our work on vaccination, which is, since we had the first community-acquired case, we were able to obtain that, and we're doing testing right now on vaccination, both in animal models that we have as well as in humans. But the hour is late. We have gone over already, and one of the things we've always promised people is that we would not keep them beyond what our commitment was, because like it or not, all of us have additional work to do today and have actual requirements that we're required to do this afternoon. So what I prefer to do is delay that next half-hour presentation to a time when we can do it in the future, when we'll have a little bit more time. I certainly wanted to thank everyone for their time today. And
Bill,
perhaps we can just
Bill,
go
before
around.
you thank everybody, we have scheduled 30 minutes of discussion time for those who want to stay and
What I want
discuss.
to do is let's go around and have everyone sign off or sign in as to specific questions they have with the current presentation, rather than open up a whole new presentation, because it was a good half hour to discuss our treatment protocols, advanced testing, and vaccination protocols.
We will schedule Bill's 30 minutes presentation on our next University of Best Practices, which is just a couple of weeks away. And then we'd love to hear from Dr. Flynn about what's happening in San Diego in urgent care, if you're still there and wish to speak with us from the phone.
Hello, Hattie, can you hear me?
There he is. Hey, Scott. Thanks for joining us.
Just a quick part to add into what's currently going on. The inpatient is very similar to what's been described, the going to virtual visits, etc. The other unique thing is I work in urgent care, and just had a shift yesterday. We have the same triage area that you've heard described out front. And if people screen positively, they go into the tents. And if they screen negative, they get to come back into the regular urgent care. We're all wearing masks in the regular urgent care, and you're all donned up with the PPE out in the tents. The interesting thing is the screening criteria, and I know what we're using, but a consideration that's always in the back of my head, and other people probably have some perspective on this, is the folks that you're asking them questions and they don't really realize that what you're asking is what they have. And so they may or may not answer those screening questions appropriately and end up back in the regular urgent care anyhow. And people that aren't fully suited up in PPE. The second question, of course, is those that are shedding virus for those couple days before they are symptomatic. And so how do you detect those? You don't. So there's still a calculated risk going on with folks that are coming back into the regular urgent care for face-to-face visits. And that's something that we consider, and that's a risk that we are accepting right now. And I don't know a better way to do it if anyone happens to know that. So that's all I've got to add to the conversation. It is interesting times, as we say. Well, one other thing, our regular urgent care volume has dropped dramatically. I heard someone say earlier that folks are staying away from the EDs and everywhere else because they're afraid of coming in and getting something also. So we have seen that also. But the stuff that is coming in is absolutely needed. So people are, I'm not seeing the worried well with 2 days of symptoms of colds and demanding antibiotics. We're not seeing any of that. Doing lacerations and broken legs and twisted ankles and heart attacks and those kind of things. The folks that are coming in are ones that need to be seen.
So Scott, how are you protecting yourself?
We are protecting ourselves when we're out in the tent. We have the gown on, a pair of gloves, just a regular surgical mask. The only ones using N95 masks now are nurses if they're getting swabs. And I know that debate with CDPH and CDC is going back and forth about if you really need the N95 mask or not. Goggles and the face shield. So we're pretty well protected out in the tents. In the back of the regular urgent care, we are using just regular surgical masks, both on ourselves and on the patients.
Does anybody have an idea of when we're going to get proper supply of N95s?
So N95s are being made right now. The suppliers still turning them out. They're available from China right now as a similar to an N95. And I would think that we will be able to have supplies for everyone in a month. So, but we are a month away from having current supplies. If the pandemic continues, then it continues to draw down on it. It's a very special piece of equipment that makes an N95 mask. So they cannot be just turned out by having people go home and sew these masks. An N95 does require a special piece of equipment that has to be manufactured. So I think we're a month away from having actual adequate supplies. We still may have to triage those supplies if the pandemic continues. Hopefully we see a bending of the curve that we're hoping for. And with that, we should be able to hopefully catch up.
It is notable, Bill, that the N95s that are commercially available at 10 times their usual price.
Mm.
Correct. The price went up significantly, partly because they had to ramp up, partly because, interestingly enough, those transports from China used to be put on commercial airlines that would fly over. And so transport cost about 8 cents a mask at that point in time. Since we have stopped commercial airlines from China coming over dramatically, they have to charter a flight to do that. And to charter a flight to bring over something as light as masks in a box is expensive. And that's added about $1 or $1.50 per mask just for the transport cost. But you're right, the cost went from less than $1 to an average of $4 or $5 an N95 mask at this time. In some places, if you do not have an established supplier, they are charging $10 a mask.
Bill, I think it would be great if you could talk a little bit about some of those therapies that you were going to talk about in your presentation, and you'll certainly have more to say about it next time we get together virtually. But I think people are looking for what is the latest on the therapies and on the various approaches to tackling this monster.
So there are clearly about 30 agents that are out there that are being tested at this point in time. We have used those agents. We have at least anecdotal evidence that some of them are work. They're antiviral agents. Remdesivir is certainly one of those. We have agents that seem to block the junction or the activation of the spike on the virus, which is required before it joins or meets the ACE2 receptor and brings itself into the cell. In addition, there are therapies that may reduce the attraction or the opening of the door through the ACE2. And the other antivirals really relate to replication of the RNA within the cell. Obviously, our cells make all of the COVID-19 virus. We make all of the parts of it. And then our parts and our cells actually help assemble the COVID virus before that is released from the cytoplasm of the cell to then go out into the bloodstream or lymphatic areas to to circulate around the rest of the body. So each of those has a specific enzyme or chemical reaction that takes place, and we have specific agents or protocols that actually attack each of those. And as I said, in about a half hour, we could go over those and discuss them, but I'd rather do it when we have time to, to discuss each of those areas. As far as the original patient that I received of community-acquired COVID, which was the first US case, we actually grabbed the blood samples from that patient, and after 10 days, we were able to finally get a CDC test that showed it was positive at that time. Subsequent to that, and with the difficulty in getting testing, we have ramped up and developed our own tests based on that first patient that we had, N of 1, and we're now able to do thousands of our own COVID-19 testing for both our staff and our patients that come in. So obviously testing is important in the mitigation phase, and it will be very important, I think, in the next phase where we're trying to track cases of COVID-19 as we go on to the future for it. As far as the serology, we've also obtained and are studying the antibodies that were done. We have a very extensive primate center, one of 5 in the US that is available right now. And in those, we have developed other vaccines for viruses, including HIV, including SIV, and feline immunoviruses and others that are fairly close to this virus. And so we have a lot of prior experience in developing what we think is ways of getting that virus to express itself. And the key is we want the respiratory cells to have this immune capability. So we don't want to wait until it's already in the respiratory circulation and affecting those lung cells. We want the respiratory cells and epithelia to be resistant to this if we develop an effective vaccine. So we're trying to short track this vaccination process. We have experience with other vaccines, which we have developed for Zika virus and others, where we have this experience of trying to accelerate the response from the vaccine. So those are all in the cooker at this point in time, and people are actively working on it today, as you can imagine, because of the enormity of the situation that we have and the speed with which we have to come out with these. And hopefully we'll have these develop. We do have it already in testing in primates at this point in time, and we look forward to those results. There's a variety of agents that are available for actual treatment in those individuals. And remdesivir that Tony mentioned, we've had positive experience with that. Most of those patients also get on azithromycin to prevent bacterial infections at the same time in those individuals. And those are the patients that we've had success with when we start that therapy early in those individuals. And other specific targets depend on the actual enzyme that we're trying to interfere with at that time, and they have shown promise. But these all require, I believe, and I think you would all agree, they require randomized clinical trials. And cardiology in chronic disease has succeeded because we have randomized clinical trials that we are using in each of those situations. That's the only way we really know that we're doing a good job, and the benefit is greater than the risk in those individuals. So that is clearly a requirement for all of these trials to go through. And we will probably need cooperation with other centers so that we get big enough numbers in these randomized clinical trials to truly show that we have statistically significant benefit greater than the risk in those situations.
So I would love to hear about what your experience is at UC Davis Medical Center. I saw some information from Stanford this weekend where they have a much lower census of COVID than they were anticipating based on Santa Clara being a hot spot. How about what's going on in Sacramento? And then Dr. DeMaria, can you address that next, please, for San Diego?
So yeah, I saw that for Stanford was a little less, but San Jose seems to have a little higher prevalence of it in their hospitals. So it may be that Stanford got missed on that. Yes, we haven't seen a huge surge. We have a couple dozen COVID-19 patients in the hospital at this time. Some in the ICU, some in the waiting for it. Clearly, if you treat COVID-19 in the hospital, you have to be aware that unlike influenza, these patients can suddenly deteriorate. So as Tony mentioned earlier, they come in in the viral period, and then they will get progressively more short of breath. And what we've seen is sudden turns where you can't really walk away from the patient saying, okay, they're breathing comfortably, they're on 4 liters of oxygen, they're out on the floor, they should be okay. We'll see them in the morning, their temperature is less, we're comfortable. That is not a stable situation. We have seen patients precipitously change within less than an hour and go from that state to where they need intubation. So we now accelerate their entrance into the intensive care unit so that there is a nurse in their room every 5 minutes monitoring them at that time. We're not comfortable leaving them out on the floor. So they deteriorate rapidly. They have to go on a ventilator. We found that on the ventilator, low volume is often the best for those individuals. So make sure you set the volume settings on the ventilator so that it's lower respiratory volume, so you're not overstretching the lung, which precipitates potentially more damage at that time. The disease primarily affects in the pulmonary intubated patients the posterior part of the lungs. And for that reason, you'll see that we've flipped over our patients so they so-called proning. So we've elevated the posterior part of the lungs as they lie on their stomach on a ventilator, which requires some manipulation by the nurses as well. So rotating them around and trying to relieve the pressure on the pulmonary circulation or the pulmonary lungs is an important aspect. And realize that these patients don't get well in 2 days and go back out on the floor. They have required longer ICU hospitalizations for a week to 10 days before they actually seem to turn the corner and develop hopefully enough antibodies that they can suppress the viral load at that time. And part of this is also waiting for the inflammatory situation to calm down as well. Part of the damage that we see with this is viral, and part is the inflammatory reaction or the systemic inflammatory response that they get. So it takes longer, more patients are intubated. Individuals with existing cardiovascular disease, diabetes, hypertension, or chronic lung disease are at higher risk for getting the disease, higher risk for going into the ICU, and higher risk for dying of this disease. So we have to be respectful of the association between chronic disease and this infectious disease.
To that point, we have had a couple of questions about whether diabetics and cardiovascular patients who are in good control are having better outcomes if in fact they get COVID-19.
So it's hard to say. I saw Liz's question earlier on control of hypertension. If it's well controlled, does that put them at higher risk? Well, the difficulty is when these patients come into the hospital, it's a little hard by the time they're admitted to judge whether their hypertension was well controlled or not. All we know is they had a history of hypertension and were on therapy at that time. By the time they come in, they're often dehydrated because it does give you some GI side effects as well with diarrhea, and they're often eating less. They lose their sense of taste and smell. So we've seen people lose significant 10 to 20 or 30 pounds during their hospitalization with this. So by ingesting less, drinking less, by the time they come into the hospital, you could, with a history of hypertension, you could say, oh yeah, well, their blood pressure is well controlled now, sure, because they're not feeling well, they're sick, and they may in fact get hypotensive from the disease. So it's hard to put an assignment, is that hypertension controlled, or is that temporary hypotension because of the illness that they're going through? So it's very difficult to say at the time they enter, are they well-controlled hypertension or not? And most of the studies have just said they have a history of hypertension. And unfortunately, history of hypertension does raise the chance of them getting the disease and of not doing well with the disease, especially in the older populations who have a higher prevalence of hypertension.
I wonder if Dr. Sky or Dr. DeMaria or other co-chairs that are on the phone or chairs that are on the phone would like to talk about their experience at UC Davis, and Travis with regard to those same issues.
So, Hattie, I think that the thing I would say is that, knock on wood or formica, whatever you want, that we have ginnied up. We emptied our hospital of elective patients, and we ginnied up. Projections were that we would be somewhere around 100 COVID-19 patients, and maybe even more than that. The most we've ever had are 20, and we have less than that now. Now, thank God for that. But it's interesting that for some reason, I mean, watching the television for a week or two, several weeks ago, and seeing these hospitals in New York and in Italy or Spain, where there's patients on the floor and people running around like crazy and whatnot. We geared up anticipating Armageddon, and it just has not happened yet. But with each passing day, seems less likely to happen. And so, I would second all the things that Bill just said. Our experience so far, I have to say that still, if you wind up on a ventilator, the reason that they show these patients who got off the ventilator getting applauded as they leave the hospital is that the statistics on that are not very good.
Tony, I asked that question on one of our planning calls with our Stanford and UCSF co-chairs, Dr. Nurali Vora from Stanford and Dr. Evelyn Stock from UCSF. And they said they're having a much more positive experience than what we're seeing in the write-ups. Also, Stanford is feeling like the remdesivir trial that they're part of, especially for the early patients, is pretty promising. So we hear these promising stories out of the leading institutions, and yet you look at the State of California daily briefings that hopefully you're all getting in your email, and they show, I think as of last night, maybe 1,200 people in the ICU in California. So I have not seen a map of where those people are, but that's one concern, that although the UCs and Stanford, and I don't know, Mike Hockman or Steve Chen, are you seeing a lighter caseload than you were anticipating?
Mike can probably speak to that, but I can tell you that if you look at the DHS websites, the hospitals for the most part are not terribly overloaded. I looked, I think last Friday, I believe, if I recall correctly, that the total number of patients who are hospitalized for COVID are somewhere in the neighborhood of 80-ish or so from all 4 hospitals, Rancho, Olive-View, LAC, USC, and Harbor.
Well, someday you'll have to coach me on how to better use that site. But I have to say, I'm impressed that we still have 67 participants on the phone with us at 30 minutes after the hour. And I just process check here. I'm happy to continue as long as our co-chairs would like to on this call. But
I've got to sign off, Hattie.
okay, Tony, bless you for partnering with us on this really special statewide right care initiative gathering of people from the 4 WINS, from the 4 regional university of best practices, who came together to help share best practices in this quickly evolving situation. And it's nice that we've now had 4 video virtual university of best practices together, and it seems like the community is really appreciating what Dr. Balmer, Dr. DeMaria, Dr. Chen, all of our wonderful presenters have been helping to coach the community on how to cope with this unprecedented emergency. So I have to say, I couldn't be more pleased with how our team is pulled together to work on yet another important area of best practices as it's evolving. And I wish you all safety. Many of you are frontline practitioners, and I worry about you. And with that, I'll hand the microphone to Dr. Balmer, our chairman of the Capital Region, and say thank you.
Well, thank you very much, Tony, for that presentation, and to all of our presenters today, clearly showing that it takes a village to handle COVID-19, and it's going to take all of our efforts in the future to hopefully reduce the consequences of this terrible killer virus. But as I said earlier, we do have weaknesses in the virus that we can exploit, and I think that ultimately we will succeed with this. And I want to thank everyone for taking the time this afternoon to participate with us. We really appreciate it and the team approach. I have to leave as well, so I will say my goodbyes and thank you everyone, and have a great afternoon, and get back to work. We have a lot of things to do. Thank you very much.
Signing off, everyone. Thank you so much. Bye.